Okay, once again, thank you everyone for joining us. So before we start, we would like to say a few introductory remarks about Yetena Weg. Okay, Yetena Weg is registered in Pennsylvania, USA as a non-profit, and it's run entirely by volunteer members. So we currently have more than 70 active volunteer members spanning across 5 different countries and counting more. As you can see from the image on the right upper hand corner, this is a picture showcasing some of our volunteers at a get-together. So our projects and engagements can be seen in 4 aspects. The first is our health promotion, which is done via discussions and articles that are written regarding the health of the general public, health policy and its implementation. Our second project and one of our strongest engagement is our community engagement, where we organize blood drives, inclusivity or equity projects and fundraising campaigns. Our third and our largest project is mentorship and skill sharing, where we provide direct mentorship, soft skill career and professional development webinars for all healthcare professionals. And our last, including this, is our continued medical education project, where research and quality improvements and the CME are partaken. So, as I've tried to mention, these are some of our programs. We have previously Clubhouse, but currently Telegram live sessions, our CME sessions, our mentorship team, our health and advocacy, research and quality improvement projects and engagements. So our health promotion team has Telegram live sessions, and podcasts where they provide health-related health-related information sharing to the general public. Our mentorship team mainly prepares workshops and trainings for healthcare professionals. And our other is our health advocacy team, where we provide inclusivity, sign language trainings, inclusivity SRHR trainings, blood donation drives, and previous Clubhouse discussions. Our other engagements through our research and quality improvement team is the Yetena Weg Research Fellowship, which is done in collaboration with HOHA Health, Black Line of the Kurambasa Specialized Hospital, and St. Paul Hospital Millennium Medical College. The first round has already been concluded, and the second round is well underway. So when we come to our CME projects or continued medical education, our CME webinars are freely accessible. Yetena Weg partners with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, and the Ethiopian Society of Internal Medicine, such as this one, to provide continued training for healthcare professionals. We had 39 CME webinars held in 2024, and our average webinar attendees spanned from 150 to 200 healthcare professionals. So for 2025, we've planned to have more than 30 webinars focusing on emergency, surgical, and medical cases, ENT, pediatrics, OBGYN, and more. So we invite renowned local and international speakers. So you can access our previous CME sessions by going to our Yetena Weg YouTube channel. And you can also get updates about our upcoming CMEs by following our Telegram channel for healthcare professionals or by following our social media posts. The handles of each respective social media will be pasted in the chat box shortly. In order to get the best experience in the webinar, we ask that you send your questions to the Q&A or to the chat box. And at the end of the webinar, your questions will be addressed by the guest speaker accordingly. So in order to get CU certificates, you must fulfill the following set of criteria. The first is attend the whole sessions virtually. The second is fill in the Google form for personal details and attendance. And the service gets 50% and above on the post-webinar quiz. So you'll get your results right away, but certificates will take up to 2 weeks to be delivered to your email. So we ask that you wait patiently in the meantime. So this is all about Yetena Weg. So I would like to introduce our guest speaker today. Our guest speaker today is Dr. Beka Aberra. He's a consultant internist, a clinical lipidologist and nephrologist with a distinguished career in medicine and academia. He completed his medical training at Addis Ababa University and specialized in internal medicine at St. Paul Hospital Millennium Medical College, followed by fellowship in adult nephrology at Addis Ababa University, where he now serves as an assistant professor. Dr. Beka is a National Lipid Association board certified lipidologist with additional training in lipid metabolism and atherosclerosis from the Open Medical Institute in Salzburg, where he received an award for an excellent case presentation. He also has completed global health courses from the London School of Hygiene and Tropical Medicine and the NIH, actively involved in professional organizations like the Ethiopian Medical Association, the Ethiopian Society of Internal Medicine, and YALI. Dr. Beka is dedicated to advancing healthcare and has contributed to community health initiatives, including voluntary medical services in the remote regions of Ethiopia. So, Dr. Beka, it's a pleasure and an honor to have you with us. You can proceed, and thank you.
Thank you very much for that introduction. I'm really humbled by that. Thank you. So I want to say thank you for both Ethiopian Society of Internal Medicine and Yetena Weg for arranging this webinar. So what we'll be discussing today will be on acute kidney injury. I hope you can all see my slides. This would be my outline for this presentation. We'll have a brief case discussion, some introduction, definitions of AKI with recent updates, patient evaluation, how to evaluate patients with AKI, and how to prevent and manage AKI. So coming to the case discussion, so just remember this case as you go along. A 60-year-old African man with diabetes and hypertension, known CKD, baseline creatinine was 2, admitted with severe pneumonia and acute gastroenteritis. So his admission creatinine was around 2.8 and it bumped up to 4.6 on the third day of his admission. So the first question is there any acute kidney injury? So the second would be, what would be the probable cause and what makes this person at high risk? What are the risk factors you identify in this case? So as we proceed, so which formula will be at least nearly perfect to tell about his current kidney filtration rate? Would you use the MDRD equation, the CKD-AP, or the Cockcroft-Gault, or would you say, no, I could not calculate his eGFR at the moment? Then the patient continued to have GI symptoms. His BP dropped. He got into shock. Tachycardic, became anuric. Electrolytes and ABG were normal at that stage. So again, another question is, what would be your preferred fluid choice? Again, what would be your preferred fluid choice in such a case as this? On the next day, his GI loss decreased. He was intubated and he was put on vasopressors. And still he was in shock. And he had an intratracheal bleeding, tube bleeding, ecchymosis, GCS dropped. His potassium became 7.1. ABG pH was 6.9. And what would be the next step in the management of this patient? Okay. So coming to the introduction. So when we come to the kidneys, we have 2 kidneys, and previous data used to say that we used to have like close to 1 million nephrons in each kidney. But now recent estimates are saying it's close to like 300, 400,000, and there are significant variations between individuals. And what are the major functions of your kidney? Excretion, metabolism, fluid balance, solute balance, and endocrinological like erythropoietin and all that, the parathyroid hormone functions. Okay, so coming to the naming of the kidney problems, like going back in history, we can go back to the days of William Herberton during the 19th century, where he used the term ischemia renuralis, where he wanted to just focus on the urine output at that time. So whenever the patients had decreased urine output, he used the term that. And then in the 20th century, William Osler used the term acute Bright's disease. And that was like a historical term, like a British physician named Richard Bright. So he just observed inflammations and damage to the kidney, and he called it acute Bright's disease. And then during the First World War, it was named as war nephritis. Yeah, obviously during the war, we had a lot of infections, a lot of trauma, physical trauma. So it was named as war nephritis. And then Second World War, named as crush syndrome. There are some papers that were published that showed rhabdomyolysis, and they named it acute kidney injury as crush syndrome. And then in the early 20th century, Homer W. Smith named the term acute renal failure, which has been used for a lot of time, but acute renal failure did not encompass the different stages of acute kidney injury. So because of that, that term was changed to acute kidney injury, which was an umbrella, a broader term that would encompass many of the kidney injury before the stage of failure. So that is a current definition we use. So acute kidney injury is a sudden impairment of kidney function resulting in the retention of nitrogenous waste products. normally that were cleared by the kidneys. So it's a clinical diagnosis and it's not a structural one. That's very important because sometimes we see reports where like radiologists or radiographers, they just do an ultrasound and they say this patient has acute kidney injury. So you cannot diagnose acute kidney injury by an ultrasound. It's not a structural diagnosis, it's a clinical diagnosis. And the two important parameters for the definition are serum creatinine and urine output. So these are the two that have been used to define acute kidney injury since the KidneyGo published the landmark guideline, the 2012. Obviously, it's a bit old. Now we're in the 2025, and maybe within this year or next year, we will have an updated KidneyGo. So I'm going to give you a brief insight into what you're going to be seeing in the next guideline as well. So serum creatinine and urine output were used to define AKI in the KidneyGo 2012. So AKI can range from asymptomatic transient change in their labs to rapidly fatal derangements. And you can come across the terms azotemia, uremia. It's just a simple term saying nitrogenous accumulation of waste in your blood, azotemia. And once you have clinical features, it's labeled as uremia. So it's not a single disease. AKI is not a single disease. It's a designation of a heterogeneous group of conditions that are sharing a common diagnostic feature. So coming to the definition, I think most of you would have come across this table. So you can see AKI basically using urine output and creatinine to define it. So with the different criteria. So you had the rifle criteria, the AKIN criteria, and the KidneyGo. So each one has its strengths and weakness. We can't just dismiss one and the other. So for example, when you see like studies that have compared AKIN and rifle criteria in the critical ICU patients have revealed no substantial difference in detection, but there have been found cases like the original rifle criteria failed to detect like 9% of cases that were detected by the AKIN criteria. And again, the AKIN criteria missed around 26% of cases that were detected by the rifle criteria. So if you ask me what's the best criteria is, I think it's the KidneyGo criteria, which use the combination of both the AKIN and the rifle. So if you can see, it says serum creatinine 1.5 to 1.9 times from the baseline within 7 days. So the 7 days is not part of the AKIN criteria. It's part of the rifle criteria. So it included that. And then it included the absolute value of increment of 0.3 within 48 hours of the AKIN. So KidneyGo is a combination of both the rifle and the AKIN criteria, which I think is the most suitable one to use. And of course, there's a urine output where we have less than 0.5 ml per kg per hour over 6 to 12 hours, and then stage 2, stage 3 progressing, going ahead. So this is an important table. Both AKIN and rifle have their strengths and weakness. The combination of both of them is the KidneyGo criteria. Again, what are the limitations of AKI definition? Obviously, creatinine. Creatinine is not an ideal functional marker, and all patients that we encounter as acute kidney injury aren't oligoanuric. They could still have good urine output, but still have acute kidney injury. So these are some of the limitations of this criteria. So change in serum creatinine occur late than the actual kidney dysfunction, usually like after 50%, after you lose like 50% of your glomes, then the creatinine starts to increase. So that's a significant limitation. Age, sex, muscle mass, drugs, protein intake, illness, your fluid status, all affects your serum creatinine. And creatinine is a functional marker. It's not an injury marker. So there is no single ideal biomarker for detecting acute kidney injury, but a combination of these markers may be required to improve prediction. So from all the new latest biomarkers that are coming, I think the NGAL is a very significant biomarker. The NGAL, there has been like an explosion of studies on NGAL. Like there are close to 2,000 studies on NGAL, the neutrophil gelatinase associated lipocalin, which is a damage marker, unlike creatinine, which is a functional marker. So the NGAL just to give you an insight, like the troponins, the good investigative markers for like the cardiac cases, their area under the curve is like 0.5 to 6 to 7. So their ability to detect an acute infarction is around there. When you see the NGAL, it's the area under the curve is close to 0.8 to 0.9. It is significantly specific and sensitive. So both the serum and urinary NGALs is a marker that's currently being used in most of the developed nations. It's expensive, obviously it's expensive, but it detects damage of the kidney before the rise in creatinine, which is a functional marker. So that's very significant and a game changer. So you're going to see a lot of talk on NGAL, especially probably in the KidneyGo, the new update of the AKI. If it comes out this year or next year, you're going to hear a lot about NGAL. More than 2,000 studies. So functional markers, obviously, you have the serum creatinine, cystatins, and the stress markers, and also the damage markers. Just focus on the NGAL. That's the most important one. And then again, this is a very important slide. If you can see, okay. So you can see this slide. It shows you, you can see like a heat map, okay? You have the functional marker, the creatinine and the urine output, and then you have the damage markers, which is the NGALs, okay? So you can see this terms, you haven't, I don't know if you've heard of it before, but you're gonna hear about it a lot, maybe this year or next year and afterwards, after we see the KidneyGo guidelines. So we have basically 4 terms: the no AKI, subclinical AKI, functional AKI, and AKI. So when we say no kidney injury, we're saying the creatinine is okay, urine is okay, the NGALs are normal. When we say subclinical AKI, we're saying the creatinine is okay, the urine output is okay, but the NGAL is rising. The damage marker is rising. This is telling you the kidney is getting damaged before the creatinine rises. So this is a significant definition, and you're going to be seeing this definition a lot. So subclinical AKI needs a lot of focus and treatment. It has treatment implications. If you treat your patients in this stage of subclinical AKI, you can prevent them from progressing to AKI. And then again, another term is what we call the functional AKI, where you have a raised creatinine and a decrement in your urine output, but the damage marker, the NGALs, are normal. So this again is significant clinically because usually you have patients in the wards, in the ICU, where you want to initiate them on ACE inhibitors or dapagliflozin, but your nephrologist would say, like we usually have conflicts with cardiologists and others by saying, let's wait a bit until the creatinine drops and normalizes, until he has some good urine before you introduce some of your ACE inhibitors or your DAPA. So this is important. So if you have this labeling of functional AKI, you can give your ACE inhibitors or dapagliflozins because there is no actual damage to the kidney. It's just an increment in your creatinine and a decrement in your urine. So again, significant terms: functional AKI, subclinical AKI. And then obviously we have what we call the term AKI, where you have both raised in creatinine and you have a raised NGAL with elevated damage marker. Yeah. So why is this important? Again, there's a study that showed that dialysis mortality, combined dialysis morbidity and mortality, is significant in those with subclinical AKI as equivalent or near equivalent to those who have AKI. So that's significant. You can have a normal creatinine and your NGAL can be positive. So this will tell you that the chance that this patient will be heading towards dialysis is high, or the chance of this patient dying or succumbing from your kidney problems is high because he already has damage marker positivity without his creatinine elevating. So detecting your patients early before a full-blown AKI is important. So again, this is just to show you what I've been saying. We have what we call this reversible AKI. where you have a fall in GFR, and then you have subclinical AKI, where you have damage markers, tubular injury, positivity. These patients usually progress. They progress to AKI, and if not treated, they would progress to like end-stage kidney disease or chronic disease. So this is significant. But those who had just like a bump in their creatinine and urea output, but without damage markers, their chance of reversibility is very high. So again, another terms that you're going to be seeing in the new guidelines would be the term acute kidney disease. So acute kidney injury and CKD we are familiar with, but acute kidney disease is a new term. So what we mean by acute kidney disease is a patient who has an acute kidney injury, and then he has passed the first week, the 7 days. He hasn't reached the third month to label him as a chronic. So these are patients who are in between. So this is a new term known as acute kidney disease. So these patients have kidney damage, but it's less than 3 months, and it's above 7 days. So these patients are significant because their projections are not known. If you neglect these patients and you don't follow them up properly, they would progress to CKD. So this is significant again. So we have a patient with acute kidney injury, they can recover, or they can like continue with their kidney problem, but not reach chronic kidney disease. They're in between. They're known as acute kidney disease. And if you get potential opportunity to treat these patients by preventing AKI recurrence, preventing progression to CKD, maybe the use of RAS inhibitors, maybe the use of selective mRNA receptor antagonists, that's questionable, needs studies, maybe the use of this dapagliflozin and others, you can help them recover. But if these patients are neglected, they would progress to chronic kidney disease. So again, this is a new term that's coming, and it's good that you should be aware of these terms. So acute kidney disease incorporates AKI and fills the void between AKI and CKD. So this will impact your on the patient's outcome, developing or worsening comorbid condition, the number of times the patient has been hospitalized and all that. So acute kidney disease is more common than acute kidney injury based on the Venn diagram that you see. And diagnosis of acute kidney disease incorporates markers of kidney damage, like the NGALs. And acute kidney disease is under-recognized and is associated with poor patient outcomes, meaning these patients, if not followed up properly, would progress to chronic kidney disease. So recognition and appropriate management of acute kidney disease will improve patient outcome. And then going to another discussion usually that I face is this patient having acute kidney injury or chronic kidney disease? So the distinction is simple. If you have a baseline creatinine, which was available like a couple of months ago, that would help you know what status of what the kidney status is. If not, you can use radiological studies like ultrasound. If you see a small bilateral shrunken kidneys with thinned out cortex, then you can suspect this patient could have a chronic kidney disease, and some other lab parameters like your intact parathyroid hormone. There was a meta-analysis that was done to compare how to differentiate AKI from CKD that used ultrasound and PTH. Well, the PTH cutoff that was used in that meta-analysis was 170 or 80. We don't use that here in our setup, which I've witnessed among many colleagues and peers, because most of us are vitamin D deficient and our PTH can be slightly elevated. But if you have like a significant PTH, like 300s, 400s, it takes time to develop secondary hyperparathyroidism. So these patients most likely have a chronic kidney pathology. So that's an important thing to remember. So coming to the epidemiology, it's very variable among the Westerns and Africa. I wouldn't say it's that variable. The only reason Africa is low is because we have less data. That's what I believe. Because we don't have that much data, but we can see AKI is common worldwide and it is rising. Why? Because of the increase in hospital care, the increase in life expectancy and all that, AKI prevalence is increasing. So estimates of AKI prevalence is very wide, as you can see, less than 1% to 66%. What is the reason? The reason could be the inconsistent use of the standardized AKI definitions during the studies. That's why it's this wide. And the etiology and incidence of AKI differs between the high-income countries and the low to middle-income countries. So AKI complicates 5 to 7% of acute care hospital admission and up to 30% of ICU admissions. And the incidence of AKI is variable and it's believed to be growing, like I said, because of the increased life expectancy, the increased interventions that we're doing, many PCIs, many contrast, many surgeries that are being done. So AKI incidence is increasing worldwide. So AKI is associated with increased risk of days in hospitalized individuals as high as 50% in the ICU. So if you remember during the COVID pandemic, if patients with COVID developed acute kidney injury, their chance of dying is significantly higher. So AKI complicating patients is dangerous. So community-acquired AKI and hospital-acquired AKI, you have this volume depletion, medication use, erratic medication use in our communities. Hospital, sepsis, surgical procedures, and critical illness are some of the causes. The recent study that I found, I think it was like in the November 2024, November 1, 2024. So it was a systematic review and a meta-analysis, and it's examined like 19 studies, and around 12,000 patients were part of this study. And you can see the prevalence was around 3.2%. But what was interesting is the studies that were included post 2020 showed significant rate of acute kidney injury. And obviously, this is most likely due to post-COVID. So post-COVID, we have a rise in acute kidney injury based on this study. Post-2020, the studies that were included had more AKI. So coming to the etiology, you know the traditional category of pre-renal, intrinsic renal, and post-renal. This is an old way of classification, but it's still usable. Old but gold, still can be used, but there is a shift again that you'll probably will be seeing in the new guidelines that would be focusing on precision medicine. So we'll be discussing on that. So this old one just shows you like pre-renal, you'd say hypovolemia, decreased cardiac output and all that, intrinsic renal, glomerular problems, tubular problems, vascular problems, and then of course post-renal bladder outlet obstruction and all that. So the recent one that's updated, it would be this one. So I would advise you to read this. So this is very important. Now you'd come across this new terms like AKI phenotype and AKI subphenotype. So when we talk about AKI phenotypes, we're like, you can use a mnemonic LION, if you can see it here, LIION. So L is for low perfusion dependent state, like usually secondary to the 3 V's, which are volume, vascular, ventricular. So this is the phenotype, AKI phenotype. And then the subphenotype would be the mechanism of the injury, hypoxia. Most of the time it's hypoxia. So volume, vascular, and ventricular. So when you come to the volume decreased with tubular injury. What would be the specific biomarkers you would check from the plasma would be LDH, malate dehydrogenase, lactate dehydrogenase, and all that, where we have this anaerobic metabolism. And then potential mechanism-specific biomarkers, you'd check plasma, KIM1, and GALs for the damage markers. And then the treatment would be specific, like inhibition of injury pathways. There are some drugs that are currently under study that can help with mitochondrial injury and apoptosis and so forth. So this is what we call precision medicine. This is coming. Precision medicine is coming. So you need to update yourself on this. So volume decreased without tubular injury. You just replace the volume. Volume, which is increased like in congestive heart failure and other hypoalbuminic states. What would you check? You could check their IVCs by ultrasound. You can check collapsibility. You check the B lines. And what would be the treatment? Fluid removal and plus or minus giving albumin. And then you can go to vascular dilatation, local, like splanchnic vasodilatation in hepatorenal syndrome. So these patients, what would you check? Their portal venous pressure. You can check their urinary end-gal, which would be low to normal. It's very interesting because Hepatorenal syndrome patients, usually when they die and when you do postmortem, their kidneys are very healthy kidneys, no damage. That is why their NGAL is low. So the treatment would be just supportive treatment like vasopressors, which was studies is the telmipressine, and then you can give them albumin as well. And then again, if you have patients with vascular constriction like obstetric AKI, eclampsia, and all that, so you can check the placental growth factor and the soluble factor together. What would be the treatment? Early termination of pregnancy, antihypertensive drugs. This would help the patients with eclampsia, preeclampsia, obstetric AKIs. And then you have vascular flow interruption, like patients with increased intra-abdominal pressure, abdominal compartment syndrome, So this patients, obviously, what you do is relieve the abdominal compartment. So you just deflate them from you can tap some amount of fluid and you will see improvement in their urine output. So I have faced some cases with abdominal compartment syndrome. It's quite interesting. I had like a patient with severe mitral stenosis and had significant distension in her abdomen and all that. And then she became oliguric, anuric, and all that. And then when we tapped her, she started opening up, became polyuric with Lasix. So I'm just saying there we see some case of abdominal compartment syndrome. So again, vascular flow interruption, treatment, decompression. And then ventricular decreased, left ventricular decreased output, where we have ejection fraction low. These are like the typical cardiorenal syndrome patients. What would be the treatment? It would be diuretics, inotropics, vasodilators, diuresing them. This could help these patients. And then you have patients with right ventricular output decrement with their TAPC being low. Then you give them this phosphodiesterase inhibitors, nitric oxide vasodilators, and all that. And then when you come to the eyes, we have the inflammatory and the immune, where you have to address the inflammation, the vasculitis, and the complement activation with your immunosuppression and plasmapheresis, rituximab, and all that. So specific managements. And then when we come to sepsis-associated AKI, again, the mechanism being inflammation, microvascular activation, and all that. So what would you check? The CRP, procalcitonins, the damage markers, the damage-associated molecular patterns, and all that. And then you can check the NGALs and all that. Management would be source control, sepsis control, antibiotics. And there are some studies talking about metformin helping sepsis-associated AKI. Well, it's interesting. So yeah, it's something to look upon. I'll be discussing about that maybe at last slides. And then obstruction of obviously that management would be de-obstruction. And then finally the nephrotoxic and envenomation, which is poison. So these patients, again, of stopping the offending agent, supportive management, some sort of short course immunosuppressive agent. So there is the old classifications are old. The new ones is the AKI phenotype and AKI subphenotype based on the cause and the mechanism. Okay, this is what we call precision medicine. Then coming to your patients, you just do your history and physical exam. If you have a patient with like pre-renal conditions, asking about vomiting, diarrhea, polyuric states, and use of drugs that cause diuresis, and you check if they are hypotensive, you check the JVPs lows, the skin tugger, and all that. And then, of course, you give them fluid. And if they respond to fluid, most likely it's some sort of volume-related condition. And then post-renal conditions, you check if they have history of prostatic disease, nephrolithiasis, pelvic or para-aortic malignancies, and then you can check for nephrolithiasis, obstructive causes, prostatic diseases, bladder enlargement, and all that. And then when we come to the intrinsic AKI causes, you check for sepsis, you have shock with ischemic ATN, nephrotoxic drugs, contrast administrations, and then, of course, we have the GN glomerulonephritis, where we have also extrarenal manifestations with palpable purpura, pulmonary hemorrhage, sinusitis. And then interesting, the atheromembolic diseases, where we have this, when you do PCIs and all that, and these patients will have this livido reticularis on their skin. And then patients with tense abdomen, you can diagnose acute abdominal compartment syndrome. So these are the things you should be focusing on during your history and physical exam. And then, of course, having a patient with complete anuria is very rare. You will find oliguria, oligoanuria, but anuria, it has to be either complete urinary tract obstruction, renal artery occlusion, overwhelming septic shock, severe ischemia, like in the patients with postpartum hemorrhage, severe proliferative GN, RP GNs, which are very severe. These are very rare, complete anuria. Oliguria, less than 400 ml over 24 hours, usually denotes a more severe AKI, and it's than when the urine output is preserved. Obviously, when you have patients with AKI and they have urine output, it's comparatively better than oliguria because it tells you there is a functional renal reserve. There is some sort of renal reserve with the patients. That tells you something that it tells you the chance of recovery is good. So coming to patients who have urine volume which has preserved in the presence of AKI, like nephrogenic DI patients, tubulointerstitial disease patients, nephrotoxicity with this platinum-based chemotherapies and the aminoglycosides, gentamicin and all that. So not only the volume of the urine, but also the color would give you a clue for your diagnosis. If you see a cola-colored urine, always you should remember glomerulonephritis, cola-colored urine or like coffee-colored urine. Yeah. So AKI results in a systemic inflammatory response, damaging most of your organs, your heart, your kidney, your bones, your intestine, liver, lung, and all that. So several complications can be anticipated from the uremia, hypervolemia, hyponatremia, kalemia, acidosis, infections, bleeding, cardiac complications, arrhythmias, pericarditis, and all that. So patient evaluation with your investigations, obviously we start with the renal function. You check the urine, you check your electrolytes, you check your CBC, your hemoglobin, your CBC for infections. You check your ultrasound for the kidney size. You can do kidney biopsy for those with unexplained AKI to get to your diagnosis quickly. And then, of course, if you have glomerulonephritis, you check your ANA, ANCA, anti-GBM, complements, anti-double strand. And also you check if there is a glomerular problem with your 24-hour urine protein, and then your septic workup, and then the Adams factors for the TMAs, the thrombotic microangiopathies. So I think we have discussed on this renal function. A very interesting point to mention, when you have this, what we call contrast-associated nephropathy, the rise in creatinine is usually within the first 24 to 48 hours. This is very important for you to remember. And it peaks within the first 3 to 5 days, and it resolves within the first 5 to 7 days. So contrast-induced AKI has been changed to contrast-associated AKI because there is no direct cause and effect relationship between the contrast and the kidney injury. So now it's labeled as contrast-associated AKI because your comorbidities, your drug intake, the type of contrast you use, these are some of the factors that affect it. And coming to your urine analysis, of course, you will see your WBC castus, RBC castus, eosinophiliuria in allergic interstitial nephritis. You can check your crystals in the uric acid nephropathy, oxalate nephropathies, acyclovir use. You can see your crystals and all that. So I have this few slides. You can check them online where you see crystals in the urine, where you have this triple phosphate crystals, usually infection, calcium oxalate with this envelope type of crystals, the dihydrate one, the uric acid, and also the other crystals in the urine that can help with your diagnosis. Coming to the ultrasound, obviously, simple bladder catheterization can rule out urethral obstruction. Patients who have like previous STDs, like elderly patients, just simple catheterization can do the trick. And then you can check your ultrasound and you can check dilatation of collecting system, hydroerythronephrosis, as you can see on the slides on the top side where you have communicating pelvis. And you can check like retroperitoneal causes of fibrosis and all that through other imaging modalities, your MRIs and CT scan, if you're suspecting like IgG4 disease or something in the retroperitoneum causing fibrosis. if there's high in clinical index of suspicion for obstruction, despite your normal imaging, you can do antegrade or retrograde pylography to reach to your diagnosis. So kidney size could be normal in the presence of CKD, like in patients with diabetic nephropathy, HEVAN, amyloidosis, either infiltrative diseases. So just kidney size alone will not help you rule out CKD. Normal size kidneys are expected. Normal slide are expected. So in AKI, so that's very important. Vascular imaging, if vascular imaging is also important if venous or arterial obstruction is suspected. Kidney biopsy, again, acute kidney failure without a clear cause would require kidney biopsy. Prevention and management of AKI, identifying high-risk patients, fluid management, treatment of underlying condition, management of complications, and of course, renal replacement therapy. Okay, so which patients are at high risk of developing acute kidney injury? Those who are dehydrated, who are volume depleted, those who are elderly, geriatric, female patients, obviously because they get pregnant and all that, obstetric history. Black race, again, more comorbidities with hypertension and DM. That's why CKD patients, always remember AKI is a risk factor for CKD, and CKD again is a risk factor for AKI. And then, of course, post-op patients, operative patients are at risk. Chronic disease patients with heart, lung, liver, diabetes patients, cancer patients, patients who are anemic are also at high risk. Patients who are in the critical care units, in the ICU and ARDS, obviously use the SOFA score. One of the components is kidney. So all these critical patients are at high risk. These are patients who are at high risk for developing acute kidney injury. So a very important point maybe for this slide today is parameters for assessing fluid status. There is no one method that can be recommended above others, but this is very important because we see some mismanagements that are very sad, like patients who are dehydrated, who had diarrhea, who are polyuric and all that. And then their physician gives them Lasix just to see their urine. I mean, it's like putting fuel on the fire. It's like it's like when you give the patient Lasix, he might produce urine, but you're causing more damage. You're not addressing the fluid status. Just simple things to check, like body weight changes, your input-output balance, his BP, his heart rate. Is there also orthostatic changes, his urine volume, capillary refill? These are the things you can do clinically. Does a patient have pulmonary edema, raised GAVP? This can tell you the fluid status indirectly, clinically. Paraclinical matters, maybe we don't have the urinary sodium, the FeNA, and all that. But you can use these basic things and then address how you manage your patients. Like if you have a patient who is dehydrated, fluid behind, and he comes to you oliguric, and if you give him Lasix, you lack the basic fundamentals of assessing fluid status. So you just need to give him fluid. That's what's important. But we see patients who are pumped with Lasix just because the patients are oliguric, but it's because they are lacking fluid. So I really want to emphasize this point for those who are attending here. Assessing the fluid status of your patients is key, mandatory, very important for the patient. And then if you get the chance in a good setup, we have static measurements, dynamic measurements. You can check the IVC, you can check the ejection fraction, you can do passive leg raise test and all other methods. But I recommend just check his body weight status, check his tongues, check if he's dehydrated. Don't be focused on his urine alone. Low urine doesn't mean you should give him Lasix, okay? Very important point. Okay, so proceeding. Fluid management in both hypovolemic and hypervolemia are associated with poor outcomes. So both restrictive versus liberal fluid therapy, there are a lot of studies. I'll briefly go through them just to give you a highlight. Which one is better? We can't say one is better than the other. What is currently happening, what is the current rate is giving patients bolus of fluid as required based on your timely assessment of fluid status. Okay, so fluid status assessment is challenging in the critically ill patients, but you can use different parameters. So coming to the studies, let's look at the old one, the relief study, which was done in the 2018. So this study included surgical patients with major abdominal surgery, and it compared restrictive fluid regimen versus liberal fluid regimen in managing these patients. And it was more or less the same, except AKI at 30 days was significantly higher with the restrictive arm. This is just one study. But again, there was another classic trial, the Clovers trial, that showed there was no issue with restrictive fluid regimen. And actually, the current rate, maybe in the recent months or year, you'll see new studies saying the restrictive approach is actually better than the liberal approach. So ongoing debate needs different studies, but it's a good thing to note. So what do we recommend? Fluid should be given based on your fluid balance and the rate of fluid removal, and targeted therapy to correct dehydration or a clear fluid deficit that you have identified. That is what's recommended. So more effective as a preventive strategy. And just giving patients boluses of fluid without assessing your fluid status can actually worsen your renal condition and can prolong the patients on dialysis. So renal outcomes, mortality, benefits of fluid therapy are yet to be established, but you can cause more harm in patients by just liberally giving them fluid. So what we recommend is targeted therapy based on the fluid status. Again, the salted saline and the smartly balanced study again showed among non-critically ill patients, there was no significant difference in hospital-free days between treatment with balanced crystalloids versus just saline. So again, this is a choice of fluids. The previous was liberal versus restrictive. Now is, should we give saline versus balanced crystalloids like ringers and all that? So again, no significant difference. But among the critically ill patients, maybe in the ICU, use of balanced crystalloids had a slightly better outcome when you compare to DES, kidney replacement requirements, and persistence of renal dysfunction. So slight benefit with the ringers in the ICU, otherwise more or less the same. So maybe if you ask, I would say, what should I take from this? There is no ideal solution that will suit all your problems. Again, saline remains to be a valid first-line option for fluid therapy. And maybe if you have patients with traumatic brain injury and cerebral edema, it's best to avoid this balanced crystalloids like the ringers. It's better to give them hypertonic saline, not to worsen cerebral edema. Other than that, there is no significant difference with your fluid choice. So no randomized trials comparing IV fluids to placebo. Again, crystalloids are preferred. Which one? Normal saline versus balanced, we have just discussed. Colloids have no survival benefit, may cause harm if they remain in the IV spaces. Okay, so this is just a summary, the SALT-TED and the SMART trial, and then the recent the PLUS trial, which was a multicentral study that was done in the Commonwealth countries, and the BASICS trial, which was done in the Brazil in 2021. Again, no difference between saline and balanced crystalloid, okay? Okay, coming to prerenal AKI, crystalloids are preferred in the setting of traumatic brain injury, like I said. A very important point to notice is excessive chloride administration from your saline can sometimes lead to hyperchloremic metabolic acidosis and can impair your GFR. So you should be cautious with your chloride administration from your normal saline. That's one point to note. And coming to prerenal cause like hepatorenal syndrome, administration of IV fluids first to rule out prerenal causes, and then you can diagnose your hepatorenal condition. Obviously, the management would be because there is splanchnic vasodilation, vasopressors with albumin. And then coming to the acute genes, of course, immunosuppressive agents, plus or minus plasmapheresis. If you have allergic interstitial nephritis, stopping the offending agent and then giving them a short course of steroids can help. If you have AKI due to sclerodermal renal crisis, do not give them steroids because it will worsen the condition. Give them ACE inhibitors. If you have patients with TTP-HS, the TMAs, you can do plasma exchange and sepsis, focusing on sepsis management and source control. Hydration as a main therapy in rhabdomyolysis patients and tumor lysis syndrome patients, very important, targeting their urine output close to maybe 200 to 300 ml per hour for your rhabdo patients. We have had significant amount of rhabdo patients usually during this recent conflict time. And we also TLS patients based on their body surface area. You can resuscitate your patients close to 2 to 3 ml per body surface area. Again, this is what I've been discussing. Use of diuretics. We recommend not using diuretics to prevent AKI. We suggest not using diuretics to treat AKI except you have confirmed that your patient is volume overloaded with a raised JVP, signs of pulmonary edema, signs of congestion. Unless you have that, don't give diuretics. You are only treating yourself and not the patient. Some physicians treat themselves by giving them diuretics, and when they see good urine output, they think they're doing well, but they're actually doing worse. So unless the patients have volume overload, don't give them diuretics. Although loop diuretics are often prescribed in the established AKI, a meta-analysis confirmed that they are not associated with reduced mortality or improved kidney recovery. Other meta-analyses have shown that loop diuretics do not affect mortality, need for dialysis, and others. Multiple studies have shown that furosemide is harmful and causes AKI when given to prevent AKI. Coming to dialysis, renal replacement therapy, obviously when your medical management fails and when the patient is uremic, you dialyze. Again, a question comes, early dialysis versus late dialysis. This question is only for those who don't have indication for dialysis. Meaning, if they have indication for dialysis, there is no question, you dialyze them. If they are uremic, refractory hyperkalemia, refractory to medical therapy, refractory fluid overload, any indication for dialysis, you dialyze them. But for those patients who are in the critical care unit and you know they are going to dialysis, but they don't have the indication yet, there have been different studies comparing early initiation of dialysis versus late. And the consensus from all this study is there is no difference. The initial ELAINE trial, the only trial that showed that favored early kidney replacement therapy was the ELAINE trial, which was done in Germany, a single center study. And again, most of the patients that were included in this study were very healthy patients that would have recovered by themselves without any treatment. So surgical patient who would have recovered by themselves. So that's why it showed a slight skewing with the early therapy. And then subsequent AKIKI 1, AKIKI 2, Ideal ICU, START AKI, all multicenter, large sample size studies showed there is no difference between early initiation of dialysis versus late initiation of dialysis. Management of complications of AKI, fluid overload, you manage with your restrictions, diuretics, and renal replacement therapy. Hyperkalemia, you can use your regular insulin with dextrose, albuterol, calcium gluconate. There is a recent move that's saying let's stop giving insulin, just give them bolus of the sugar, because when you give your patients bolus of sugar, insulin surge will be done by your body if you are healthy. So that's a new thing. And then hyperphosphatemia, phosphate binders, hypocalcemia, calcium carbonates, acid-base imbalances. You can give your bicarb if your patient is not congested. Otherwise, if you give bicarb and he's congested, you'll worsen his congestion because it has sodium. Uremia, again, encephalopathy, pericarditis, PPIs, desmopressin. And then again, malnutrition, how to manage malnutrition, a complication of AKI. You need to give them appropriate caloric intake. Again, another importance like drug adjustment in cases with acute kidney injury. It's complicated. Serum creatinine does not accurately measure estimated GFR. That's like it has a lot of limitations. The volume of distribution of your drugs is affected by the change in your total body water. Underdosing of drugs, especially antibiotics, occurs a lot. Patients who have life-threatening infections. So in our setup in Tukur Ambassa Hospital, we have stopped adjusting antibiotics, especially like meropenem, where you have life-threatening infections during the first loading doses, and sometimes even in the maintenance doses. We only check if the patient develops seizures or some sort of central nervous system complications. Otherwise, it's better to give them more antibiotics, because if you don't control your infection, you are underdosing your patients, and the patient will deteriorate. It doesn't matter anyway. So this is very important. What we have been noticing is a lot of patients are underdosed. So drug dose should be adjusted if your creatinine is above 2. Assume patients with AKI have an eGFR of less than 15. Consider drug level monitoring, very important. Considering higher loading doses with no or reduced or unchanged maintenance doses. Frequent dose adjustments are mandatory. Sometimes we see patients, their antibiotics are adjusted and they are recovering, but the medications are not adjusted. So they are still getting low dose of what they should be getting properly. So you should go along with your kidney function in the way you are adjusting your drugs. You can see the time of insult and then how to adjust individualized risk-based adjustment, adjust renal excreted drugs when your GFR comes down, and then reintroduce your drugs, consider drugs with renal protective effects. Need of dose adjustment, plenty amount of drugs that need dose adjustment. So you just check based on their injury markers and functional markers how to go about it. Outcome and prognosis of AKI. AKI is associated with significantly increased risk of short and long-term mortality, prolonged lengths of stay, higher healthcare costs. The kidneys may recover even after severe dialysis requiring AKI, but with extremely high risk for progressing to CKD. And up to 10% may develop end-stage kidney disease. So you need to evaluate your patients, especially with the new term that's included, the acute kidney disease, less than 3 months. If you discharge your patients with AKI, you need to see them like within 2 weeks, then within a month. And if you can do something, if they're recovering, good. But if they are progressing, you need to do something before they progress to CKD. So repair and recovery, if you have a normal adaptive recovery, they can go back to their initial baseline. But if you have a maladaptive recovery, these patients could progress to chronic kidney disease. This is, again, a very important slide, very interesting, actually. This is actually a single patient. And this one patient, you can see in 1999, his GFR was close to 70. So this guy developed AKI, okay? So, and then close to the 2000s, his GFR dropped because of that acute insult, and his GFR dropped close to like 65 and all that. And then he recovered, and his GFR again went back. But notice, he did not go back to his previous ones. It's a bit lower. And then again, he had another bout of AKI. So his GFR dropped and it again plateaued. And then look, his new GFR is now down to 70, less than 70. So you can see AKI is a risk factor for progressing to CKD. Every single episode of AKI, you are losing a certain amount of glomes that you will never recover back. So this guy again had another bout of AKI, and then his GFR dropped, recovered a bit, and then another bout of AKI dropped. Finally, you can see this patient progressed within the 2005. He is now within the end-stage kidney disease category. So significant within, I don't know, like 6 years, he had a significant amount of AKIs, finally went down to end-stage renal disease. Yeah, so AKI is a risk factor for CKD, and again, CKD is a risk factor for AKI. So this is a vicious cycle. So you need to identify these patients, check their risks, and address the risks. Like some of the risks you cannot change, like age, race, genetic factors, but you can address hypertension, you can address diabetes, you can address metabolic syndrome. These are the things you can do to prevent this vicious cycle where the patients drop down to end-stage kidney disease. So maybe the last slide would be this one, things to look out for, trends to watch in 2025. Obviously, the new KDIGO guideline with regards to the AKI, it has been close to now 13, 14 years. The last one we had is a 2012, which is a golden guideline, which changed a lot of things. Things to watch out for, One, the inter-organ communication between the kidney, which is being documented a lot. We have the hepatorenal, cardiorenal, now recently gastrorenal for the IgA nephropathy and all that. So the kidneys seems to be a vital organ communicating with a lot of our organs. So researching, highlighting crosstalk about the kidney, gut, heart, brain, lungs, and others. Second, advancement in prognostication and managements, biomarkers to improve risk stratification, the NGALs to identify AKI subtypes, AKI phenotype, AKI subtypes, and all that. Ultrasound guided diuretic therapy and muscle ultrasonography for fluid management. This is what we call targeted fluid resuscitation, not liberal, not restrictive, targeted fluid management. And then again, third is novel therapeutic pathways, like I mentioned, metformin for sepsis-associated AKI. Exact mechanism is not clear, but it's said to be metformin activates this activated protein kinase, which is a key regulatory factor in the cellular energy metabolism. So it gives the kidneys rest. That's what it says. And then mesenchymal stem cell therapy and all anti-inflammatory agents and all that. So these are some of the things to watch out for. These were some of my references, and thank you. If you have any questions, I yield my time.
Okay. Thank you very much, Dr. Beka. That was a very interesting practical session today, to say the least. So thank you very much. We have a few questions that have been forwarded in the Q&A as well as in the chat box. So we'll directly proceed with them. I'll shortly share my screen and we can go over them. Okay, so the first question is, does NGAL differentiate between AKI and CKD when patients present for the first time with raised creatinine?
Yeah, that's an interesting question. Probably needs to be studied, but it doesn't differentiate acute kidney injury from chronic kidney disease because NGAL is a damage marker. So the patients could have acute kidney injury, could have an NGAL which is elevated, and CKD patients could have an NGAL which is elevated. It will not help in differentiating these two. But very important point is the NGAL, you should really focus on this. More than 2,000 studies now. It is a very good damage marker. So NGAL is good in labeling patients. Like, for example, if you have an AKI patient and his NGAL is high, then this patient has a high risk of progressing to AKD, acute kidney disease. So during that phase of his period, before he reaches CKD, you should do some intervention, so whatever is necessary, before he progresses to chronic kidney disease, if his damage markers are continuing to rise. It's actually very interesting that even in the post-transplant patients, they're checking NGALs in post-transplant, and those patients who have a post-transplant NGAL which is high compared to those who have a post-transplant NGAL which is low, those who have a post-transplant NGAL which high, they usually develop graft failure. So it's a good agent, but it will not differentiate AKI and CKD at this time. Okay.
Thank you very much. The second question reads, can we give enalapril for a patient with CKD and a serum creatinine of 8?
Okay, so that one I think needs clarification because if you say CKD with a creatinine of 8, you are saying end-stage kidney disease. So can you tell me who asked the question and if they can elaborate it? Because with a creatinine of 8, your GFR is less than 15. So could you tell me who asked the question? Could they elaborate your question? So no, the answer will be no, unless the patients are already on ACE inhibitors, like based on the STOP AC trial. And if they progress to end-stage kidneys, it doesn't matter whether you stop it or not. But introducing ACE inhibitors with a patient who has a creatinine of 8 during that's not just CKD, that's end stage, that's not recommended. So I know the question. So maybe if I could clarify, if you have patients with functional AKI meaning you have a raised creatinine, decreased urine output, and your NGAL is normal, that means you don't have damage markers which are positive. These patients, usually their creatinine is not like this, 8 or something. It's just slightly high, like 2 or 3 or something. And your cardiologist would say, this patient has a myocardial infarction. I want to start ACE inhibitors. And usually the nephrologist would say no. but based on this new functional AKI definition, if the NGAL is okay, I would recommend go ahead with your ACE inhibitors, go ahead with your dapagliflozin.
Okay, thank you very much. The second question, I think, has been addressed in the presentation as well, but it reads, is
Yeah, so
GFR estimation
it's,
important?
yeah, excellent. So I already, okay, it's part of the question. So no, because GFR is a glomerular filtration rate and it's an estimation. It's not an actual measured GFR. We are estimating the GFR based on a creatinine. And creatinine should be done in a stable state. There should be a stable state of production and removal of creatinine for you to estimate GFR. So in an acute condition, you don't estimate GFR, rather, you just assume that GFR is less than 15.
Okay, thank you. So the fourth question reads, what is the place of 30 ml per kg sensitivity and crystalloid therapy in AKI?
I don't see. Okay, where is the question? I can't see it.
The fourth question, place of
Place
30
of,
ml per kg sensitivity
huh?
and
I don't
crystalloid
understand the
therapy in
question.
AKI.
I don't
Okay,
understand the question.
okay. In the meantime,
What
I
is
think
it?
the person who asked the question can offer their clarification in the chat box. We can
Yes,
proceed with
that
the
would be
next
good.
question.
Yeah.
The fourth question is the place of renal adjusted dose of antibiotics for AKI and CKD.
Mm.
So when should we
Mm-hmm.
change into renal adjusted from a normal dose?
Yeah. So what we suggest, usually, if you have a drug leveling capabilities, you can do it based on that. But we suggest that you don't adjust, especially your cefepims, meropenems, and all that for the first few days. And then you can start adjusting if you want for the maintenance. For example, for the meropenem, where you give your loading dose, no need to adjust. Only watch out for central nervous system, seizures, and all that. That's the only thing you need to watch out for, because it's better to treat the sepsis. And then when should we change into renal adjusted from a normal septic dose? Again, I don't want, what does that mean? When should we change? Anyway, so my point is no need to adjust in the first loading dose of your antibiotics, okay? In the case of acute kidney injury, where your creatinine is usually above 2, GFR is less than 15 for all AKIs, okay?
Okay, thank you. The sixth question is sort of case-based. So a patient had a serum creatinine of 15.4 and serum electrolytes showed hypokalemia, hyponatremia, and hypochloremia, but urine output was adequate. So how should we manage this patient?
That's quite interesting. So this looks like a patient who's losing a lot of fluid. I don't know. Is he polyuric? Urine output is adequate alone? What do you mean? Hypokalemic, hyponatremic, hypochloremic? Like what? Does he have diarrhea? Does he have is he polyuric? Is it a pre-renal condition? I hope he can elaborate. Like, what's his blood pressure? It needs more elaboration, this question.
Okay, so you can elaborate further on the chat box as well. So we'll proceed to the
Yes.
next question. The next question is place of specific therapies like steroids in AKI patients.
Again, this is not, I don't know what kind of questions. Okay, anyway, so steroids or immunosuppressive agents for confirmed glomerular pathologies, not all AKI. AKI it's not a diagnosis. AKI is a heterogeneous group of patients. So if you have a glomerular pathology where you have a rapidly proliferative glomerular type of GN, then steroids, high dose steroids would have a place. And then patients who have interstitial nephritis and who are projected where the creatinine is rising, you can give them short course steroids. So that's my answer. Okay.
Okay, thank you. The eighth question is, do we have NGAL in our setup?
We don't have NGAL, but there are some institutions, I think, that do have it, some private institutions, but we do. It's very expensive, very expensive.
Okay, thank you. The ninth question is the management of a patient in shock with fluid overload and with AKI.
Yeah. So this is a kind of patient where you need to diurese them. So diuresis, if you are sure your fluid assessment, JVP is raised, he has pulmonary edema or bilateral pleural effusion, you are sure he is congested, diurese these patients, diurese them, because the congested state will worsen the AKI. Sometimes when you diurese them, their AKI might resolve as well. So continue with your diuresis.
Okay, thank you. The third question is, in our setup, how can we proceed with salt and water restriction, and by how much?
Yeah, so salt and water restriction in our setup, we usually just say don't use salt, but we have this the food preparation already has salt, so less than 2 grams a day would suffice, like less than 2 grams a day. Yeah, and water restriction. Water restriction is for if you have a patient who is in a congestive state, like cardiorenal syndrome, hepatorenal syndrome states, and if you are sure that he's congested. Okay.
Okay, thank you very much. The next question reads oliguric versus non-oliguric AKI and its effect on management and prognosis.
Yeah, obviously, like I mentioned, if you have a patient with oliguric AKI, their prognosis is not good because their functional kidney reserve is poor. It tells you that it's poor. But if you have a non-oliguric AKI, where you have like 2 liters, 3 liters of urine, and their creatinine is high or their NGAL is high, yes, your management will have an impact, but you can be rest assured that their prognosis is much better than the oliguric ones because they are at least filtering it out. So they have some glomes to filter it out. So their functional kidney reserve is better.
Okay, thank you very
Continue.
much. The first question is, I think it's already been addressed as well. What
Yeah,
is
yeah,
the
yeah.
recommended method?
No, 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 we don't need to
So,
ask that one because we said we don't
yeah,
need to do. Okay. You don't need to
thank you.
calculate EGFR in the state of AKI.
Okay, thank you. So the
Okay.
13th question reads, how long should be the renal adjusted antibiotic be given? And should it be prolonged or should it be adjusted for a conventional duration?
Again, not a clear question. I've tried to address that as well. But what I recommend, meropenem, for example, you can use the infusion, a prolonged type of giving, rather than just the conventional type. And of course, giving the loading dose full, and sometimes even giving the maintenance dose as well. Okay.
Okay, thank you. The 14th question reads, so one of our attendees shared their experience. So they're seeing a patient with malaria-associated AKI with serum
Yeah.
creatinines exceeding 20
Yes.
milligram per deciliter,
Yes.
but
Yes.
stable. So is there any explanation for this?
Yeah, that's an excellent question. I don't know who asked that, but what I want to say is we are seeing a lot of malarial associated AKI currently. Usually these patients have nephromegaly. I don't know if this guy could also respond if that's his also experience. Their kidney size is like 14 centimeters. So they have nephromegaly and high creatinine, but the patients are stable. Some of the patients they deteriorated and we had to dialyze them in Tukrambasa. I don't know his experience, but most of them they recover by themselves. Again, I don't have any explanation, but we are planning to collect these patients and maybe write a case cohorts, case series of these patients because it's quite interesting. We are seeing a lot of malarial cases with nephromegaly, creatinines of above 20. They are stable. Usually they recover by themselves, even becoming polyuric at the last phases of their recovery. So it's very interesting. So I hope this guy could communicate me the 14th question.
Okay, thank you. The 15th question has already been addressed previously. So we'll proceed to the 16th. The 16th question asks if there are any injury markers in CKD.
Again, that's interesting. Yeah, there are markers, different markers, but more than that, in CKD is doing a biopsy, and that will tell you there is interstitial fibrosis or tubular atrophy. That will tell you there is a chronic process rather than markers. Markers are important in the early phases, like in the acute kidney injury, in the acute kidney disease phases. But in the chronic state, it's not that important. You can do a biopsy, and if your interstitial fibrosis is significant, if your tubular atrophy is significant, then the chance of recovering of this kidney is very low.
Okay, thank you. The next question reads, how do you address diuretic resistance in cardiac patients?
Yeah, that's interesting question. So there is a study that showed the use of acetazolamide in these patients. where you have maximum dose of Lasix close to 40 milligram per hour on infuser, and then you maybe add thiazides, so sequential blockage. And then finally, addition of acetazolamide has helped some of our cardiac patients, not all. I have experience with this. We had a patient who was diuretic resistant. We were about to dialyze her, and then we gave her, why not give her the so the risk with acetazolamide is you will worsen metabolic acidosis. And so anyways, we gave it to her. So after that, she responded. So how to address it? If you start with Lasix maximum dose, and then if your sodium is okay, you can give a hydrochlorothiazide. And then the next step would be, if your creatinine is more or less okay, you can give acetazolamide. Ultrafiltration is not comparable. There is no significant difference between dialysis and ultrafiltration. Multiple studies have shown there is no difference.
Okay, thank you very much. So the attendee that has asked the sixth question has provided a clarification. So the patient has had a serum creatinine of 15.4. He had a history of hypertension, CKD, and chronic Hep B virus infection. And the serum electrolytes showed hyponatremia, hypokalemia, and hypochloremia, and had a GCS of 6, and he was oliguric. Currently, his BP was normal. So he's asking how to manage this patient and whether this patient benefits from dialysis.
So to make it clear, I would not dialyze a patient with a potassium which is less than 3. That's because our dialysis is already potassium of 2. So I would first address the electrolyte abnormalities, the hypokalemia, hyponatremia, hypochloremia. There must be a reason why he's having all this. Some endocrinological workup as well. The creatinine being elevated, I would check his fluid status again, check his IVC, check his JVP, check his cardiac function and all that. But I would not dialyze him with a low potassium. I will address the potassium first.
Okay, thank you. The person who has asked a question for the ninth question has also provided clarification. So the patient was in cardiogenic shock on pressure, and he was in a state of fluid overload. He was on Lasix infusion with lack of urine output.
That's quite interesting. So this is a cold and wet patient. The patient is cardiogenic shock, and then he's in a state of fluid overload. That's quite interesting. So cold and wet, obviously continue with your pressor and try to diurese him. But I will not dialyze this patient until his BP is well, because he's in shock on a pressor. He will not tolerate dialysis. In the best setup, I would maybe do CRRT, continuous renal replacement therapy, in the best setup. Even that might not help this patient because this is a cold and wet patient, so the morbidity, mortality is very high.
Okay, thank you very much. So we have just a few questions remaining. So the 18th question reads, a 30-year-old female patient with a 24-hour protein of 4,150, ANA and anti-TS DNA was positive. Creatinine was 0.85. So he or she is asking whether the patient needs renal biopsy or whether she can be started on steroids.
So to make it clear, I can answer this question, but it is off topic because the creatinine is normal. This is an acute kidney injury by definition, but this is a lupus patient, most likely. And for a lupus patient, already the immunological markers are enough to start her on, not just on steroids, actually. You start her on proper induction because her 24 urine output is more than 3 grams. So you need to start her on mycophenolate, MMF, with steroids. Okay, so steroids plus MMF, even though her creatinine is okay, but because her 24-hour urine protein is above 3 grams, so that's why I would do that. Okay, so no biopsy, MMF with steroids.
Okay, thank you. The 19th question reads, so aggressive diuresing is the background of raising creatinine in patients with cardiorenal syndrome.
Again, this question needs to be clarified. There are 5 types of cardiorenal syndrome. In which type do you mean? So based on the type, that would be one of it, because diuresing them is the treatment. Sometimes when you diurese them and their creatinine starts to creep up, that's actually a good sign. That's telling you that they are responding, that the renal venous congestion is decreasing somehow. So continue diuresing them until you feel that they are adequately diuresed and their creatinine starts to come down. So there are different types of cardiorenal syndrome. You know, you don't need to fear to diurese patients just because there is a slight bump in their creatinine.
Okay, thank you very much. So since time is a constraint, we'll only be addressing the last question. So it reads,
Again,
how
the
common is
last
TDF?
question is out of topic.
Mm.
TDF-induced renal tubular acidosis is not part of acute kidney injury.
Okay, these are all the questions we have for today. Thank you very much, Dr. Beka, for addressing all of the questions in a patient manner. So having
Thank
said
you.
that, we'll directly proceed to the post-CME quiz. Okay, so the first question is, a 63-year-old man with a history of well-controlled hypertension presents with the emergency department with fever, nausea, vomiting, and confusion. His vital signs: temperature was 38.3, pulse rate was 110, and blood pressure was 120/70. His respiratory rate was 26, with an oxygen saturation of 2% on room air. On examination, the patient is disoriented, and there is a left-sided costovertebral angle tenderness. His lab results, WBC was 18,000 with a serum creatinine of 2.9 and a blood urea nitrogen of 52 milligram per deciliter. Urine analysis showed many WBCs per high power field and the nitrates were positive. Ultrasound showed no hydronephrosis. There was no stone with a normal sized prostate. Blood and urine cultures were obtained and ceftriaxone was initiated and he was admitted afterwards. So which of the following statement about this patient's AKI is correct? The first choice is the most likely cause of AKI in this patient is ischemic ATN. The second choice reads sepsis-associated AKI is less likely as the patient does not qualify for the current definition of sepsis. The third choice reads preemptive initiation of hemodialysis at this point will improve the patient's survival. And the last choice is even if this patient's serum creatinine returns to his baseline after treatment, he remains at a risk for CKD.
Yeah, most of you have got it. Some have said the most likely cause in this patient is ischemic ATN. I don't know why you answered that. His vitals seems to be okay, but that's okay. So the answer is the last one. So like I said, AKI is a risk factor for CKD. So even if he recovers, he will have lost a certain amount of glomes that he would never recover them back again. So he is at risk of CKD. So some have said sepsis-associated AKI is less likely. I don't know why, because he has sepsis with leukocytosis of 18,000. He has nitrite positive, most likely urosepsis. So that would be my answer, okay?
Thank you very much. The second question reads, a 47-year-old woman with severe pulmonary hypertension, which was considered to be idiopathic, and a severe right-sided heart failure with anasarca is admitted for IV diuresis. Her vital signs, blood pressure was 100/60, pulse rate was 112, respiratory rate was 28, and on examination, the patient had tense ascites with bilateral pleural effusion and a class 3 edema. Her serum creatinine had increased from 1.2 to 3.8 milligram per deciliter in 4 days with progressive decline GFR. So which one of the following is incorrect about this patient's AKI? The first question reads, the heart failure can be associated with the development of AKI. The second choice is the presence of tense ascites can be associated with the development of AKI. The third choice reads, marked diuresis with significant negative fluid balance might worsen the AKI. And the last choice reads, spontaneous infusion of furosemide is superior to IV bolus dose of furosemide in effecting diuresis.
Excellent. So again, this question, you just need to read the dose study, the dose trial. So that would clearly tell you that continuous infusion is not superior to bolus infusion. Some of the people have said most have said marked diuresis with significant negative fluid balance might worsen AKI. Yes, if it is a significant negative fluid balance, it can worsen. But if it's just a slight bump, that's okay. But I understand why you say that. But you just need to read the dose trial that showed clearly that continuous infusion of Lasix is not superior to bolus infusion of Lasix in this case. Okay.
Thank you. The third question reads, a 65-year-old Hispanic woman with long-standing hypertension coronary artery disease, peripheral vascular disease, and chronic kidney disease. Preoperative serum creatinine was 2.5. Underwent a surgical abdominal aortic aneurysm repair and developed oliguric AKI postoperatively. On postoperative day 1, serum creatinine was 4 and urine output was 20 ml per hour. And after a 200 milligram intravenous, thank you. After a 200 milligram intravenous dose of furosemide, urine output increased to 50 ml per hour, and the furosemide drip was titrated to 40 milligram per hour to maintain this urine output. And you are called to consider the need for renal replacement therapy for this patient. So the question is, which one of the following statements regarding the use of furosemide to treat AKI is true? The first choice is it reduces her chance of in-hospital mortality. The second choice is it increases her risk for ototoxicity. The third choice reads it would shorten her duration of renal replacement therapy if renal replacement therapy was initiated. The fourth choice reads it reduces blood transfusion requirements. And the last choice reads it improves medullary oxygenation and decreases the severity of AKI.
Yeah, so again, this is clear. You can see that the patient is on a high dose of Lasix and her urine output is slightly improving, but with this high dose of Lasix, the side effect that we would anticipate is ototoxicity. So the true statement would be it will increase her risk of ototoxicity. Some of you said it improves medullary oxygenation. I don't know why. And some said it would shorten her duration of renal replacement therapy. So that's, again, if renal replacement therapy, if initiated, the amount of diuretics you give will not affect the duration of dialysis because that is completely different. So the amount of ultrafiltration that we adjust would not be impacted by the diuretics. Usually we stop the diuretics once we start renal replacement therapy, but it would not affect the duration of the renal replacement therapy. So the answer is it increases her risk of ototoxicity.
Okay, thank you very much. The fourth and last question reads, a 60-year-old white man with a history of hypertension and diabetes undergoes cardiac angiography with stent placement after presenting to the emergency department with symptoms consistent with unstable angina. 3 days later, he is noted to have a rise in serum creatinine from a baseline of 0.8 to 1.9. Along with this rise, he is noted to have a slight increase in eosinophils on his complete blood count. And on examination, the patient is noted to have a net-like pattern of blue-red rash on the bilateral lower extremities to the level of the ankles. So the question is, which of the following is the likely cause of AKI? The first choice reads cardiorenal syndrome. The second choice is cholesterol emboli. The third choice reads contrast-induced nephropathy. And the fourth choice is acute interstitial nephritis.
Yeah, so this is excellent. So yeah, this is quite an interesting question. And it's what I anticipated. Most were having a choice between contrast-induced versus cholesterol emboli. So I've tried to discuss about contrast-induced, actually no longer induced, but associated nephropathy, the duration, the peak, it peaks around 5 to 7 days and all that. But cholesterol emboli, if you see the timing and then the net-like pattern of blue-red rash, that is levido reticularis, okay? The net-like pattern of blue-red rash on the bilateral lower extremity is levido reticularis. So during the procedure, most likely this patient showered the cholesterols from the plaque, from the atherosclerotic plaque. So that's his answer is cholesterol emboli, but it is, I understand some of you said contrast-induced nephropathy. And again, I see some said interstitial nephritis because you just saw the slight increase in our eosinophils. So eosinophil increase by itself would not mean acute interstitial nephritis. Even the triad, meaning the rash, the raising creatinine and all that is not significantly found in interstitial nephritis as you would anticipate. So just because you have eosinophils and eosinophil is related to allergy, some of you said, I think, acute interstitial nephritis, but the clear answer is cholesterol emboli, levido reticularis on the bilateral lower extremity.
Okay, these were all the questions we had for the quiz. So on
Yes.
behalf of Yetena Weg, the Ethiopian Society of Internal Medicine, and everyone here today, I would like to extend our heartfelt gratitude to Dr. Beka for his insightful and comprehensive presentation. So thank you for taking time out of your busy schedule to be with us and contributing to the ongoing education of healthcare professionals. We hope to have more sessions with you where we can learn just like we did today. Thank you.
Welcome, welcome. Have a good afternoon.
Okay, thank you for joining us, everyone. We'll see you next time with another session. Thank you.